So let's discuss today high order aberration in the keratoconus, okay? Especially focusing on keratoconus and how high order aberration relates with keratoconus and vision. So that's the topic of today's video. So what do you mean by high order aberration? So in human eye is not a perfect optical system as we know it, but it suffers from many high order aberration that degrade the retinal image quality. Light aberration, which caused by cause would basically final thing what aberration does is the blurred vision. So aberration, when light from one point object does not converge or diverge into the single point after transmission through the lens system. This basically means I have talked in detail in my optics series. Basically, point object passes from the optical system and do not form point image, and this is called aberration. And perfect optical system with a zero aberration is not possible at all, but as far as possible we want to manage it and point our object, we want point image to be formed, but that's not possible at all. So I have already discussed this picture. I have taken this picture from my favorite author, that Professor Dr. Joshua Ismail's book. So what is this? It basically means, see, this is classical Seidel aberration. We are not going to deal with it. I have already made a sufficient amount of videos in aberration. So we are going to deal with the Jernicke polynomial. Basically, in topography, you will see Jernicke polynomial. Especially not low order aberration. We are not interested in low order aberration. But in case of keratoconus, we are interested in high order aberration, especially coma and trefoil. But coma, yes, coma is central important in case of higher aberration in uh, keratoconus. Yes, definitely high order astigmatism, secondary astigmatism is spherical aberration, but coma is the central main topic. Okay, so we have already discussed this slide previously too, which is basically zero order aberration piston, first order aberration basically tilt, horizontal or vertical tilt, second order aberration astigmatism and defocus, which is basically what we correct from spectacle. And these two low order aberration, we don't care about it because it's clinically very irrelevant. Clinically relevant low order aberration is second order aberration. From third order aberration, we starting to higher order aberration. So for third order aberration is first higher order aberration, and in case of third order aberration, what is most important is vertical coma. In case of keratoconus is very important vertical coma, not horizontal coma. Yes, threefold, yes, and we know it, the more left side is more negative, which is basically vertical. Horizontal more is shown in positive. Okay, from 0 1 2 is low order aberration, 2 is a true low order aberration, from 3 onwards, 3 to infinity is high order aberration, and in 3 there is 2 4 2 2 positive 3 4 negative 3 4 horizontal coma and vertical coma. Basically vertical coma, that is the interest in keratoconus. That's the most interesting aberration in keratoconus. Okay, so what is point spread function? That is, one point is whenever pass through the optical system, and how this point is spreads in space is called, this point actually illumination spreads, this called point spread function, which is in aberration. In case of piston and tilt, it's not, they are not clinically relevant, but from onwards, this astigmatism and coma and trefoil, and as you move higher order aberration, there is more and more and more and more point spread function spreads. Okay, so basically non-aberrated system, it look like this, and in defocus it look like this. In coma, can you see this image like vertical shifting? Trefoil, it's mean three lips, spherical aberration obviously, so it's 0.3 micrometer aberration, and it's 1 micrometer aberration, it's high. Okay, so in this picture, can you see this piston? Does it matter? No, piston is just an visual perception thing. It's not relevant in clinical case. Coma, can you see a little e just upside it? Spherical aberration and quadrifoil there. This kind of aberrations. Okay. So what are the symptoms of high order aberration? It's very important. I have put this, remember size of because you we know it. High order aberration is directly proportional to the size of the pupil, and many times it's proportional like in a square. If you people increase by double, aberration increase by four times. It's in a square. So that's why people in a small people there is always less aberration, because in small people there is less coverage by corneal refraction. So basically, what are the symptoms that we have to discuss in higher aberration patients affected by higher aberration, especially ectatic disorder? Double image, lack of contrast on crispiness, reduced color perception, glare sensitivity, night vision problem. Why? Because in night people dilates, and whenever people dilates, aberration increase by, I think, square. So you starburst pattern and comet tail around the light of at night, and these complaints may be seen in third order aberration. Basically, coma is third order aberration, and trifold is third order aberration. Halos, which is very common in another. This complaint may be seen as a fourth order aberration, such as spherical aberration. Halos is common. Okay, decreased distance in near vision. This complaint may be seen in fourth order aberration or secondary astigmatism or negative effect on vision. They describe as a central island of therapy distortion. This will push out the edge of the image. So whatever it is, basically remember the high order aberration problem shoots up in night, especially because people dilates, and as the people dilates, aberration increases rapidly. So that's the basic thing you have to understand. Okay, so this is called glare, halos, and sunburst. You can see in this picture, isn't it normal picture in keratoconus? Yes, it's basically these things. So what is keratoconus? It just go roughly. I'm not going to explain you keratoconus in perspective of like disease in detail, but I'm going to roughly discuss. Okay, keratoconus is condition in cornea assumes conical shape. That's why kerato plus conus. And result, which is basically keratoconus, is non-inflammatory, progression corneal thinning, and till date non-inflammatory. But who knows? And new studies are telling somewhere there are some debates between the researchers, but till now it's non-inflammatory. The thinning and protrusion of cornea, and which basically introduce irregular astigmatism with and without myopic, resulting to mild to mark impair in both quality and quantity of vision. So basically quantity and quality of vision reduces because of the protrusion and because of aberration. So it is a progressive disease ultimately affecting both eyes, and although one eye may be affecting initially, yes, there is always a disparity between two eyes, but it's basically disease which happens in both eyes. Yes, disparity is there. So keratoconus case, visual problem which may form large magnitude of myopic astigmatism and with blurring and distortion, ghosting and poor contrast acuity is very important. This thing, ghosting and poor contrast acuity. The retina and the post-retinal neural aspects of the visual system are unaffected in the etiology of keratoconus. Very important. Keratoconus is a disease of cornea, not a retina. Okay, and post-visual system is completely okay. So the visual degradation found compared with the normal eye is purely due to the optical deficiency of cornea, such as high. So in case of keratoconus, it's not about retina or anything or neural aspect. It's about cornea, and it's about the image that forming due to the cornea is bad on the retina. That's why vision decreases. It's nothing to worry about the retina. Okay, yes, we have to see other things as in eye practitioners. We have to sometimes there is a correlation between keratoconus and allergic disease, and correlation between keratoconus and RP, for example. So we have to see retina as cautiously as possible, but there is very less chance that keratoconus patient has vision decrease by other reasons. So that's very important. So what are the basic signs? Thinning of the cornea, yes, you can see there, and Munson sign, which is protrusion of lower lid whenever they are just it's just very sign. Box try, you have seen this is try like ding 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 ding. But box try in early cases, if you can see box try in very early, so that's always better. And sometimes it's quite tricky to see box try in slit lamp. You have to be very good with a slit lamp. So I always prefer my student to become very good with box try. I'm always fascinating to show my student box try. So that's what I did in my past. But box try, it's very important that you see box try clearly as possible. So ritudic corneal reflex, just throw light from temporarily, and there is one conical light beam shown in the nasal limbus. So that's HUD sign. World sign reflects, see, from the direct ophthalmoscope. Distant direct ophthalmoscope is very important to see Fisher ring in cobalt blue light. See this ring line. Can you see this line? Okay, so that's the Fisher line. Basically iron deposition. So localized hydrops. So if localized hydrop, there is a scar you can see. So it's very advanced stage. Okay. So measuring and diagnosing high order aberration. So high order aberration are measured using the wavefront aberrometry. The wavefront aberrometer measures the distorted light as they passes through the patient's cornea. So high order aberration are coma, spherical aberration, trefoil. These aberrations result from the visual disturbance, like as we know. These all things. This is symptoms. So how are visual high order aberration measured? So basically, by aberrometry, most common is Slack-Hartman method. Okay, it's most common, but different instrument has different techniques. So we should, I think I should refer this book from Professor Dr. George Esimelis, that I think it's ophthalmic imaging. That ophthalmic imaging book is quite fascinating book when you, if you want to read the aberrometer, by Professor Dr. George Esimelis. I think that's the great book if you want to read ophthalmic imaging book. I think I name it correctly. Yes, it's ophthalmic imaging by Professor Dr. George Esimelis. So basically, Hartman's like aberrometry means when light reflects from retina and passes from the cornea, then the small lenslet focuses, and how this lenslet focusing pattern is basically differ from the grid, normal grid, and that measurement is done by Hartman's like aberrometry. It's very important. Let's move directly to the why higher aberration and the coma in correlation. It's simply because the refracting surface quality creates a pattern of refraction that takes place through the surface. Basically means, see, this is the pupil, that this yellow line is a pupil. So I'll make it red. From this area, which is vertex, there is a less power. From this area, so it's infrared, there is a high power. So what the aberration going to be there? Simply vertical coma, isn't it? See, 4.28. Can you see? 4.28. My goodness, it should be less than 0.3. It's 4.28. At the same time, there is no horizontal coma, because difference between here and here, nasal and temporal, is same. That's why it's not there. A trefoil is three areas at different power. But remember, in keratoconus, vertical coma is way important, because the refracting surface itself, upper refractive surface has a small power, and the lower refracting power surface has higher power. Then what do you think which aberration is going to be there? It's definitely vertical coma, isn't it? Vertical coma means in one area wavefront is steeper, another area wavefront is flatter, isn't it? That's why a high order aberration means a in total of these aberration. But can you see the most prominent aberration is vertical coma, isn't it? Others are relatively smaller. So it's very simple. Okay, low order aberration is basically this. If we talk about low order aberration, then basically this, which is true low order aberration, astigmatism and a defocus. See another case. In this case, can you see horizontal vertical coma? The difference between here and here, and another horizontal coma is also there, because difference between this point and this point is higher. So horizontal coma is also there. So it's very simple. You look at this chart and you can understand how this pattern. Because see, no matter what, in case of keratoconus or in case of any ptatic disorder, it's always important. Remember this line: first high order aberration, which is third order aberration, is most important aberration. Then you can imagine others. Okay, this is second order aberration, we don't care about it, and what we do care is high order aberration, and that's a first high order aberration, which is third order aberration. You just put your eyes here first, don't move your eyes in other higher aberration, just put your eyes on the third order aberration, which is the first high order aberration. That matters a lot. So, is there a treatment of higher aberration? Yes, there is. Numerous type of adaptive optics are being developed or have been developed for the correction of higher aberration. These optics include intraocular lenses, refractive surgery, or contact lenses, especially scleral lenses. The goal of having adaptive optics is to obtain the correction of vision that can go well with the shape of the wavefront pattern and the pupil. See, in this is a great picture. I love it. See what written here. If cone is developed centrally in the keratoconus, elevated amount of spherical aberration would be most dominant finding aberrometry measure. If it happens, but it's not happened like that, is it? It happened like that, isn't it? That as the cone is usually displaced inferotemporally keratoconus, predominantly elevated amount of vertical coma and trefoil and spherical aberration as compared in normal. So basically, what is the predominant is vertical coma. That's very important. Why? Because power moves in inferotemporally. Okay. So what are the treatment? Basically RGPs, any RGPs, maybe scleral lens or corneal lens, customized contact lens, and today we have higher aberration correction scleral lens and adaptive lens system. So this is the case. Can you guess? Vertical aberration must be high because the lower is this. So you can see vertical aberration. Can you see point spread function? It's like vertically spread. Can you see vertical 4.8? It's very simple. Second case is also that it's very simple, and I have already and I haven't shown this picture. See vertical aberration 7.53, somewhere 7.53. Yes, it's very high, isn't it? And this is the case that I have already shown in my last video. In this case, aberration is 79, which is very high. And after the scleral lens insertion, it becomes 1.1. So, is there a treatment? Yes, definitely. From 79, it's 1.91. If you want anything more than that, it's perfect, isn't it? Is vision restored? A lot is vision. I think 160, it came around 618 and something like that. And that's why scleral lens we call it magical lenses, because it reduces aberration like magic. So keratoconus case, scleral lens work like magic. So that's it, because from 79 to 1.91 is crucially magical. So that's it, I think. Aberrometry and the keratoconus. I hope if I have anything else, I'll definitely make another video, but this done, choose.